Hi, my name's Dr. Stephen Gardner. I'm a neurosurgeon with the Southeastern Neurosurgical and Spine Institute and the Greenville Hospital System. I'm here today to give a brief description of the diagnosis and treatment of neck and shoulder pain, particularly as it affects the neurological elements of the cervical spine and the arms themselves. This will be a brief description of a typical bedside diagnostic evaluation with some pointers perhaps on future diagnostic testing as well as therapies that may be employed to remedy these situations. This video is intended mainly for physicians, but if patients should be able to visualize or see it, I hope it will be helpful to you as well. Let's get started. First, neck and shoulder pain is a multifaceted, multi-diagnostic problem. People who have pain generally have a hard time localizing the pain beyond perhaps their shoulder, their arm, their forearm, or their hand. So in the diagnosis of this, we have to get more certain about what may be the pain-generating sources that are causing this type of pain. For instance, a pain may be muscular or it may be skeletal. Skeletal may be related to a joint. It may be related to a cartilage in a joint, an inflammatory process of the tendons perhaps. Or the pain may be neurologic, related to a compressed nerve root of the neck, the shoulder, the arm, or the hand. So to differentiate the pain-generating source is the first key step in further diagnostic testing and ultimately therapy. I'll begin by talking briefly about the shoulder, an area that's perhaps more expertly addressed by my orthopedic colleagues. However, when I do see a patient who complains of neck, shoulder, and arm pain, the first examination is going to be regarding their neck. Is it tender? Do they have restriction of motion? Is there a particular motion that aggravates or relieves the pain? This would point to a mechanical source of pain in the neck joints and the discs themselves perhaps. The shoulder joint. It's a multi-plane joint designed to operate, as everyone knows, in a very circular manner. The first test for this would be, does the patient have good vertical, reach for the ceiling please, mobility? Are they able to prisoner clasp behind their back, that is down and back? Or can they reach across and pat themselves on the shoulder in the horizontal motion? If any of these are restrictive, it may be a good idea as to further evaluation of the shoulder joint itself. Now, as particularly relates to the nerve elements involved, which is my area of expertise, there are basically four major nerve roots that come from the neck through the shoulder down into the hand and arm that can cause pain. You have the C5 nerve root, the C6, the C7, and the C8. I'll go down in order from top to bottom. The C5 area generally comes off between the fourth and fifth vertebrae in the neck, roughly above the collar line in a male, and it will proceed to provide sensation and cause pain in what I would call the shoulder pad area. Weakness in this area is primarily confined to the deltoid muscles that will elevate the arm, pull it back, and down. So if a patient doesn't have range of motion pain and their shoulder joints are clean, if you will, and they have particular pain here, or the evidence weakness in testing the deltoids by holding their arms up and attempting to push down by the physician in this manner, then one would become suspicious of a C5 nerve root lesion. This is a very fragile nerve in terms of its motor function and easily damaged by trauma. It has the longest distance to go from the side of the neck, up high, down through the brachial plexus to its origin across the shoulder joint. So particularly rotational injuries, distraction injuries, side lash injuries are very, very fundamental in creating a C5 nerve root problem, in addition to perhaps ruptured disc. The C6 nerve root is a bit more robust. The 6th nerve root is the biceps function. Its reflex is the biceps reflex, and the sensory area that it supplies extends from the top of the scapula around down the forearm, down into the thumb, index finger, and portions of the middle finger. If you can just remember the number 6, you can remember the 6th nerve sensory area. The 7th nerve root, a bit further down, is basically your triceps muscle. This is easily tested by resisting in the fixed position as this as the patient pushes out. It's also the triceps reflex, and it supplies the 2 fingers here in the middle for sensation. Its path from the neck will create pain a bit lower through the mid-scapular area, down the back of the triceps as opposed to the front of the forearm for C6, down the back and into these 2 fingers. The last nerve root would be C7, C8, the C8 area. The C8 is going to provide sensation to these 2 fingers under the arm into the axillary area, and it is primarily a grip strength test. If you can think of the number 8, grip strength, that would be well. There is no particular reflex associated with the C8 nerve root. So in essence, if you wish to check for a patient's strength, you can ask them simply to reach up to the ceiling and unscrew a light bulb. This will get all the nerve roots in terms of their strength. You have C5, C7, C6, and C8. Check reflexes and sensory distribution, listens to the patient's description of the pain that's involved, particularly the fingers of the hand, and you can virtually make a diagnosis of which nerve root may be affected. Now, a bedside diagnosis does not necessarily lead to surgical or medical treatment. You can initiate medical treatment on the basis of a bedside diagnosis by the use of brief courses of oral steroids, cervical traction, and physical therapy. If this is unsuccessful, you may want to proceed with further diagnostic testing in the form of cervical spine x-rays, particularly flexion and extension x-rays that will check for mobility, and also perhaps an MRI scan of the cervical spine to check for nerve impingement by disc or osteophytes from cervical stenosis, which is basically a degenerative condition. Patients with pacemakers, of course, would require a CT scan as they are not eligible for an MRI scan. Ultimately, if there is confusion over whether the MRI scan is conclusive in showing nerve compression, or you fear that the nerve compression irritation may be more in the shoulder than in the neck, then I would suggest that we have our colleagues who perform EMG and nerve conduction studies, that would be the upstate medical rehab of the Greenville Hospital System and the Pain Center, perform EMG and nerve conduction studies of the upper extremity for electrophysiologic testing to determine which nerve roots may be affected in the upper extremities and how active or chronic these irritations may be. Once this diagnostic collection is made, it will then be possible to determine if the patient is a candidate for surgical treatment or medical treatment, and the appropriate referral to either medical treatment or surgical treatment could be made. I thank you for your attention to this video, and again, if you're a patient viewing this, I hope this information will be useful to you. And to the physicians, if you have any questions whatsoever, please do not hesitate to call myself or one of the other neurosurgeons associated with Southeastern Neurosurgical and Spine, as well as the Greenville Hospital System. Thank you and good day.